Thank you for joining us for today's conversation. I'd like to introduce my co-moderator for this session, Dua Elodie.
Hello, everyone. My name is Elodie, and I report on healthcare and racial inequity with a focus on maternal and child health for ProPublica. I'd like to start this session by just sharing some context around the print series on this topic. Nadia, if you can please share the slides.
There we go.
Okay, great. Thank you. So I have spent, the past 2 years reporting on stillbirth, but when I started, I knew pretty much nothing about stillbirth. Next slide, please. So what surprised me when I started reporting is that many of the people that I interviewed also said that the first time they had heard about stillbirth was after they had delivered their own stillbirth baby. And so what I found is that in many cases, this led to a lack of information and awareness that caused a lot of heartache and guilt after their stillbirth. And so what is a stillbirth? Stillbirth in the US is defined as the death of a baby at 20 weeks or more of pregnancy. And depending on when it happens, stillbirth can be considered early at 27 weeks, late at 28 to 36 weeks, or term at 37 weeks or more. And about half of all stillbirths in the US occur at 28 weeks or later. So why did I investigate? So when I heard that more than 20,000 pregnancies in the US end in stillbirth every year, I was shocked. The number of stillbirths exceeds infant mortality, which is when a baby dies before their first birthday, which I think a lot of us had heard about. It's about 10 times higher than SIDS, which again is an issue that a lot of us have heard about. There's been a lot of funding around there. And perhaps the most surprising to me was that of the 20,000 plus stillbirths every year, research shows about 25% are believed to be preventable. That's about 5,000 every year. So when I did this, I learned so much during this process. And I just want to take a moment to thank all of the mothers and fathers and doctors and nurses and doulas and midwives and researchers and advocates who spoke to me, shared their experience with me, because I wouldn't have been able to do this series without them. And we're going to meet three very special mothers and a doctor, Debbie, Kanika, Stephanie, and Dr. Stone here in a little bit. So, I mean, I think in the most simple form, what I learned is that stillbirths are not inevitable. As we said, a key study found that nearly 1 in 4 stillbirths in the US may be preventable. And when you get to 37 weeks of pregnancy or more, that figure jumps to nearly half. But what I found is that there are a lot of systemic failures that are leading to this stillbirth crisis. So federal agencies have not prioritized stillbirth-focused studies. Data around stillbirths is frequently incomplete and delayed, and sometimes just inaccurate. Federal health agencies, state health departments, hospitals, and doctors haven't done a good job educating parents about stillbirth or counseling them about fetal movement. And unlike SIDS, federal officials haven't launched a national awareness campaign, and placental exams and autopsies, which can really give us critical information, are not utilized enough. And so I pulled this graph from one of the stories because I think it really summarizes what we're talking about, that the lack of comprehensive attention and action has contributed to a stillbirth crisis shrouded in an acceptance that some babies just die. Compounding the tragedy is a stigma and guilt so crushing that the first words some mothers utter when their lifeless babies are placed in their arms are, "I'm sorry." And as heartbreaking as that is, what I learned during this investigation is that it doesn't have to be this way. And if you look at what other countries are doing, they're doing a lot more to prevent their stillbirth rate. So as part of the reporting, I went to Australia and I got to talk to doctors and midwives and go to their hospitals and meet their lawmakers who have really made stillbirth prevention a priority there. And so what other countries are doing that we're not is implementing national action plans, increasing awareness, research, and care, opening rainbow clinics, implementing perinatal audits, and adopting what are called safer baby bundles. And those bundles include ensuring awareness and education around the importance of fetal movement, reducing smoking, improving monitoring to ensure that babies are growing normally, advising side sleeping, and if appropriate, delivering before the due date. And what these approaches have led to are real results. And so the Netherlands has reduced their stillbirth rate by 57%, Australia by 35%, and Ireland by 49%. And the last, note that I want to make when we're talking about the stillbirth crisis, and a very important piece of it is to recognize that Black women and Native Hawaiian or Pacific Islander women face disproportionately higher rates of stillbirth. And there's a lot of reasons for that. But one of the reasons that this is Brooke Smith, when I spoke to her, said is that really doctors don't take their concerns seriously. And this is, I have to say, a sentiment that I heard across the board from all mothers. But, Brooke specifically said, if you're a Black woman, you get dismissed. So that's, a brief summary of the print series, and I'm so lucky to have been able to work with such a talented film team at ProPublica, and especially our brilliant director, Nadia, to make this documentary. So Nadia, would you like to transition us into a conversation about the film?
Thank you so much, Dua. This film arose from our partnership, and you've been such a driving force behind it all along. When we started working together, you were writing this meticulous, scientifically informed, and all-encompassing print series about stillbirths that showed both in broad strokes how the US had failed to address the stillbirth crisis, and in granular detail, the ways in which a lack of data collection, autopsies, research, and awareness have left major gaps in efforts to prevent stillbirths and to care for grieving families, as you just showed in your presentation. I came to your investigation thinking about how the medium of film could amplify your work and reach different audiences. I was also thinking about film as a vehicle for conveying emotion and lived experience. And so knowing that every stillbirth is unique and that every family is unique, we set out to find just a few whose experiences could hint at the wide range of stillbirth stories in America today. And we found such incredible people to participate in this film that we are fortunate enough to have with us today. And I'm going to introduce them shortly, but first, I'd like to show a trailer of the film for those who haven't seen it yet. So please just bear with me one sec on the technology front, and I will get that trailer for you.
From a young girl, the one and only thing that I ever knew that I wanted was to be a mom. I just screamed in the bathroom. He had been waiting 6 years to tell me he wanted to have children.
Oh, here are the instructions? All right, give me this.
Our wedding was the reveal that we were actually having twins.
The word stillbirth never came up ever once.
I tried to wait it out because I didn't know the condition that I had. That was the difference between life and death.
Every year in this country, over 20,000 babies are born still. So I spent the past 7 years working on a piece of legislation. Other countries have made stillbirth a national priority.
Are you guys ready to go?
We can do the exact same thing.
Let's do this.
She's kicking.
You are the next generation of birth workers.
I'm so grateful for the village that I have found.
We have the solutions to problems that we didn't create.
We're just hoping that we can see the bill make its way over the finish line. This has to happen now.
I have a baby there. It's a little hard to believe.
Making this film has been so personally meaningful and such an amazing collaboration within ProPublica's newsroom. And I just wanted to shout out a few of my team members who poured their talent, creativity, empathy, and countless hours into bringing this film to fruition. There is our director of photography, Liz Mohan, editor Margaret Cheatham-Williams, senior producer Lisa Reardon-Seville, and executive producer Almudena Toral. Filmmaking really takes a village, and working with all of you has been such an incredible experience. And now it is my honor to welcome our expert panelists to join us on screen. These are some of the faces that you just saw featured in the trailer. Is everyone with us? Debbie, there she is. Debbie Haine Vijayvergiya is a stillbirth parent advocate and the mother behind the Shine for Autumn Act, named in honor of her daughter Autumn, who was stillborn in 2011. Kanika Harris currently serves as the executive director of the National Association to Advance Black Birth. She holds a doctorate in health behavior and health education. She is the mother of 3 children the world can see, a near-miss survivor, birth justice advocate, and doula. Stephanie Lee is an associate director of nursing and critical care at a New York City hospital. She was also a patient at the Rainbow Clinic at Mount Sinai, which provides enhanced prenatal care for patients with a history of stillbirth. And speaking of the Rainbow Clinic, we have its director, Dr. Joanne Stone, who is an expert in the field of maternal fetal medicine. She is the system chair of the Raquel and Jamie Galinsky Department of Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine at Mount Sinai. Panelists, thank you so much for joining us for today's session. And I think I'm going to start with Dr. Stone and just a basic medical question that came in from the audience. Many of you submitted questions in advance, and we're grateful for those. So, Dr. Stone, what do researchers believe to be the principal causes of stillbirth?
Thank you so much, Nadia, for the opportunity to be on this webinar. There's a lot of different causes for stillbirth. There are maternal underlying diseases, things like chronic hypertension, diabetes, obesity, advanced maternal age, multiple gestations, things like that. There's also placental conditions where there's placental insufficiency, there are umbilical cord accidents, infectious disease, genetic disorders, fetal abnormalities. And then of course, the unknown is something that we always struggle with when we don't find a cause.
Thanks so much, Dr. Stone. And I just want to follow up on that question with one about preventability. So when I first started doing this reporting, a lot of people, many officials, and even some doctors were reluctant to say the word preventable, as if it was like a tacit acknowledgement of failure. But you were never one of those people. Why is it important to acknowledge preventability?
I think if you don't acknowledge it, you can't change it. You can't change anything. I mean, there are some things that are not preventable. Somebody with a lethal genetic disorder, we can't prevent that, right? But there are conditions that are preventable, and we have to be able to educate our patients so that they're informed. And we talk about fetal movement all the time. We talk about things like if you're bleeding, call right away. If you're chronic hypertensive, check your blood pressure, if you know, and all the symptoms and warning signs to try to prevent stillbirth when that happens. And so it's so important for people to realize that things are preventable.
Thank you so much for that. Kanika, in the film, you spoke so powerfully about your delivery and the missed warning signs. If you could go back, what do you wish you would have known? And what do you want to tell other mothers or future mothers?
Sure. Thank you for that question. So excited to be here. I lost my twins to preeclampsia and HELLP syndrome. And at that time in 2010, there was just no conversations around the warning signs for preeclampsia that eventually went to a more severe form of HELP syndrome. And so if I would have known about the telltale warning signs, which are severe headaches, swelling in the hands and feet or extremities, nausea, and that eventually led to, some bleeding, and that was my warning sign. Also, extreme back pain, so lower back pain is also another symptom. I think if I had known those symptoms in advance, I would not have waited. I would have gone to the ER right away.
Thank you, Kanika. Stephanie, this is a question which multiple audience members have asked. What are some recommendations on how to support a grieving family?
I think grief is such a personal, experience, embodiment. I think sometimes folks have this idea of how they would want to be supported, so they immediately, understandably, the first response would be to do exactly what you would want for yourself. But I think the best way to approach grief is to actually ask that individual how they want to be supported. Often it's not just a card, but maybe acts of service like food, going in and just listening, a hug, if someone's okay with that. I think it's really just personalizing that experience and also allowing that individual or family to grieve, not to provide solutions, trying to put a band-aid on the situation, but allowing that individual to experience it, because grief doesn't go away.
Thank you so much, Stephanie. Debbie, you told us about how after you lost Autumn, you struggled to explain to your toddler daughter what had happened. And I thought of you because we received an audience question that said, how can those with non-medical, non-clinical backgrounds, such as early childhood educators, support those experiencing the heartbreak and loss caused by this topic?
Thank you for that question, and I'm happy to be here as well. This is really so exciting to me to see the documentary finally out and to see stillbirth get this kind of attention. So how can non-medical people help? Was that the question? Sorry, I was hearing something in the other room and I got distracted.
No worries. Yes. And this audience member who asked the question talked specifically about early childhood educators who might have contact with children, support those experiencing stillbirth, since it's, experienced by the whole family.
I think, as far as educators, I think what's really important is just to let the children know that, it was not their fault, and that, is that the question? I'm just trying to, is that it? Yes. Okay. I think it's a hard one. We really struggled with Maya. I didn't have anyone, which is why I'm here, is like, I didn't have anyone to ask on what I should be doing. And I had a hard time, and I think where we netted out was just to let her know that, sometimes these things just happen, and that it wasn't anything that she did or that I did, and that we were still a family of, no matter what, and that Autumn was always going to be a part of that. And I think just being there for the family and being there in however way that they need the support, I think is really important. I think not always having the answers is okay. I think just letting them know that they're not alone going through this, and that, you're there to support however it is that they need.
Thanks, Debbie. Dr. Stone, another question for you. I mean, I think by now we've established that some stillbirths are preventable. Can you share with us some specific things doctors and patients can do during pregnancy to lower the risk of a stillbirth?
Sure. I mean, that's like so key, right? So I think one thing is even going before pregnancy starts is preconceptionally, right? So optimizing preconceptional health is so important to improve outcomes and reduce stillbirth. So for example, smoking is one of the risk factors for stillbirth. So if you can undergo smoking cessation beforehand, if you have diabetes and can get your diabetes under the best control possible, if you have obesity, that's always a tough one because people come to you, you know, like two minutes before they want to conceive, and so it's hard to say lose 50 pounds in the next 2 minutes. But you know, obviously, if you're seeing somebody and it's a year in advance, and you talk about, you know, oh, maybe you think about getting pregnant in the next year or two, you can talk about, you know, better health, exercise, eating habits, all those things. I think when you're pregnant, there are a few things. So Kanika brought up something that happened to her where she wasn't, you know, really informed of signs and symptoms of preeclampsia, which is such a, you know, not an uncommon condition and something that can be, you know, absolutely lead to not only stillbirth but maternal mortality as well. So talking about all those symptoms, you know, the headache that she mentioned, the nausea, the right upper quadrant pain, swelling, things like that, that, you know, the people should look out for. I think we talk a lot about fetal movement, and that's something that we really try to address, especially in the third trimester. And I always tell my patients, try to get a sense of the pattern of fetal movement, because different fetuses have different patterns. It's not always like just looking for a decrease or kick counts. It's about a change in the pattern of the fetal movement. So addressing that and then not waiting, right? I have too many stories of patients who, you know, felt less fetal movement. They're seeing the doctor the next day and they waited. And then, but, you know, so don't wait, you know, be an advocate for yourself and speak up. And, you know, it was brought out in, you know, in the introductory slides about particularly Black women being ignored or dismissed. You know, nobody should ever feel that their concerns are dismissed. You have to, if it means advocating for yourself, saying, no, this is what I feel, then just do it, you know. And I think those are just some of the things that we can do.
Thank you so much, Dr. Stone. And Stephanie, you were a patient of Dr. Stone, and you were also a nurse with years of experience at the bedside and overseeing ICUs. But stillbirth caught you by surprise, and as a healthcare provider and a parent of loss, what advice would you give to providers working with pregnant patients to educate patients about the possibility of stillbirth? And I know we've talked about some of that, you know, with Kanika's experience and what Dr. Stone has just talked about, but also, you know, how should providers work with families who do experience stillbirth?
I think one big thing is not making assumptions. You know, I'm an ICU nurse. I've actually taken care of numerous patients who were labor and delivery, things didn't go planned. They ended up in the surgical ICU, but we still don't know everything. Nursing and healthcare is such a huge world, and that's why there's so many specializations, and people spend years to kind of really hone their art. And so it's really easy to assume, oh, she's a nurse, she'll know. It's easy to assume, oh, she's a doctor or she's a respiratory therapist, she'll know about this stuff. And the reality is there's so much information, so much knowledge out there that it's not physically possible for one person to really know everything. I think that when we question our assumptions and approach a patient, we err on the side of kind of following cues and discreetly asking, how do you feel comfortable? Do you want me to say it this way? Do you want me to address you this way? I think we bridge that gap between patient and provider, being a nurse or a doctor, whoever we may be, and we can really connect. We're going to make mistakes. I've made numerous mistakes, countless. And I think that, in my humble opinion, I think, just apologizing if we do make a mistake and asking how to move forward, and trying to take into account our patients and where they're at, I think is really important.
Thank you, Stephanie. Debbie, a question for you. You talked in the film about the importance of good data and the need for more autopsies. Why are accurate data and autopsies so important when it comes to prevention?
Well, because with better data, we'll have better outcomes. Here in the US, stillbirth data is really, really poor, severely inadequate. And so until we have the kind of data that can help us to better understand why babies are dying, we're very limited in what we can do to protect families from suffering this kind of tragedy. So, yeah. And, as far as, I just want to add, with regards to like autopsy, it's that information that really is what is the foundation of this data. And so, that is my hope, is that, more people are offered an autopsy and more people accept, and that those who are performing the autopsies are trained, because that is such a crucial piece of the puzzle. And, hopefully we can see more trained perinatal pathologists, and we see it become more common practice for families to be able to get one and afford one. Hopefully insurance companies will get on board and start covering those costs.
And I think, you touched on all of the main points there, and, in terms of kind of being offered the autopsy, talking about it, covering the costs of it, but also, even after all of that, actually doing the autopsy. And Stephanie, that, brings me to your experience. Why was it so devastating when, even after, you and Tanati signed for the autopsy, it was not performed? What did you hope you were going to learn from it?
I think for us, the autopsy and getting it was a no-brainer. As a nurse, I know what an autopsy does and what it entails, and it was something I really didn't want for my child. But we opted for it because we wanted to know what happened. We wanted to know why. Why did our little girl go? The doctors that cared for me during that pregnancy were adamant that there was a very specific differential that they were setting on was the reason for why everything kind of happened during my pregnancy. But to us, we had no idea. My daughter had intrauterine growth restriction, which was not mentioned ever during my delivery and during my prenatal period. It was something that my friend mentioned to me when I told her how big Elodie was. So there's just a lot of things that happened that were kind of never really discreetly mentioned. And so we wanted answers. And more than anything, we still wanted to grow our family. We wanted to know if the reason that Elodie died was something that we needed to know about and could affect a future child. Yeah, like it was just answers. I think it also, at least for my husband, would play a huge role in his healing, and how he could handle his grief. And it's still a part of our family that is constantly a struggle. My husband doesn't have answers. We don't have answers. We don't know what happened.
Thank you so much, Stephanie. Kanika, I had the opportunity to observe and film a doula class that you were teaching at Morgan State University. And in the film, you share with your doulas in training how Black women in America are more than twice as likely to have stillbirths as their white counterparts. How can we start to change that?
Yes, I think we are trying, as we're not really getting too far lately, but the recent CDC data shows that, out of all of the racial and ethnic groups in the United States, Black women's maternal mortality has not gone down and continues to rise. So I feel like that answer is really steeped in the history of this country, how it was developed, how it's formed. It's not as simple as awareness and information, because we have over 20 years of data that show that a lot of the issues that we experience, such as, preeclampsia, are, tied to stress and racism that we experience in this country. So I wish I could say we address it by more awareness, more programs, but if we want to actually get to the root of the issue and start really preventing, it's got to go a lot deeper into how we're set up to live in this country. But I do feel like if we're going to take a stab at it, it just really starts with listening. One that families, unfortunately, Black families and Black mothers birthing people in this country are going to have to really step up and advocate for themselves, which is a really hard thing to ask someone to do. And then it requires us listening and understanding that these things are more likely to happen to Black people. But I think the other part of it is also understanding that it's not our fault. And a lot of times when you hear we're twice as likely for these things to happen, I remember I was told in the hospital when I lost my twins, and I said, well, why? And they said, well, you're Black, and that's just a risk factor. Because you're Black, that's a risk factor. And it's also because you were carrying twins and, my age. And so what that says to me is that my race is my fault. And so I think if we're going to educate clinicians and doctors, that has to be a huge part of it, because if your race is your fault, then there's already this ambivalence or this idea that we can't do anything because you were just born that way. So that is a big part of it as well. So I will stop there. But yes.
Thank you, Kanika. And thank you for, helping us try to get past this fatalism that, this is just what happened to Black women and we just, have to accept it. Dr. Stone, we talked briefly about what other countries are doing to reduce their stillbirth rate and, how they're really so far ahead of the US, from whether it's, their safer baby bundles, national action plans, or, the UK are, is a leader in rainbow clinics. Can you tell us why Mount Sinai, opened the first rainbow clinic in the US? And one of the audience members specifically asked about, current thoughts around inducing moms at 37 to 39 weeks of pregnancy to prevent stillbirth.
Yeah, great questions. As a maternal fetal medicine specialist, I've been taking care of patients with prior, pregnancy losses for a long time, or other adverse outcomes, things like that. But I had a few patients that came to me, and they had started a charitable foundation to try to reduce, to raise awareness about stillbirth, and also with the goal of preventing the preventable stillbirth. So they had come to me and, asked, gave financial support. And we sort of spent a year putting the whole program together, speaking with Dr. Alex Heasel, who started the Rainbow Clinics in the UK, and making sure that we were trying to model it in the best possible way, and include services like social work services, nutritional support. These are things that are really not covered under our healthcare, in the obviously the UK has a national, health system, so it's a bit easier to have those things covered. So we did need some philanthropy to get this, to get this started. So it took about a year, and we had the entire staff undergoing training. There's so much that sensitivity that people are not aware of. So, things like, wanting to know patient's history before you walk in the room, because the last thing you want to do is say to somebody who had a stillbirth, oh, is this your first pregnancy? Whatever. And I mean, so many, postpartum, make sure that that this patient had a loss, and not ask if they're having, if they're breastfeeding. I mean, these things happen, unfortunately. So it was really, really important that we start this, and also make sure that we're taking care of all patients with all insurances. So we don't deny anybody if they have commercial or Medicaid insurance. Fortunately, when you're pregnant, you automatically can get Medicaid if you didn't have health insurance beforehand. So we're lucky in that sense that we have that, that capability. And then we learned things as we went along. I mean, we learned things that we wanted to continue on to labor and delivery. So again, the same things didn't happen. We had training for some of the staff on labor and delivery. We put little rainbow footprints on the door so patients knew that this was, that this patient had a stillbirth or pregnancy loss, previously, and also through the postpartum period. So there was a lot of learning. We're 3 years into it now, and I think we so far had amazing outcomes. So on a limited number, we have to keep tracking the data, and Debbie mentioned the importance of data, and we're keeping that information. And I forgot what the second part of the question was.
No problem. Yeah, one of the audience members had asked about kind of current thinking around inducing moms at 37 to 39 weeks to reduce stillbirth.
Yeah. So, the societies, including American College of OBGYN and Society of Maternal Fetal Medicine, do not recommend inducing patients prior to 39 weeks without medical indication, because 39 weeks seems like an optimal time to prevent some of the more short-term issues around neonatal morbidity, respiratory disease, hyperbilirubinemia, jaundice, things like that, low glucose levels in the newborn. And there have been a couple of trials, one a US trial where they randomized patients who were low risk to inductional labor at 39 weeks versus expected management, and found a lower rate of cesarean delivery, as well as high blood pressure, hypertensive disorders of pregnancy developing. So there's a lot, and then there was another study for women who were 35 years old and above, randomizing them also to delivery 39 weeks. So again, showing similar findings. So I think, inducing at 39 weeks doesn't increase the cesarean delivery rate. That's a common, not a myth, but a misinterpretation of old data. So I think it's risk reducing. As far as patients with a history of a prior stillbirth, I mean, I think that even though, again, and I was the president of the Society of Maternal Fetal Medicine, even though our recommendations are to deliver at 39 weeks, I don't know a single patient that has gone through this terrible loss that can even make it to 39 weeks. So we usually will deliver between 37 and 39 weeks to try to improve outcomes. I mean, we have patients coming very frequently, as much as they want, in terms of doing monitoring. But I think you have to take into account, each individual circumstance, and also the anxiety level that people experience. I mean, when you're so anxious and you have that anxiety, I think that alone is an indication for delivery at 37 or 38 weeks.
Thank you so much, Dr. Stone. And in the scenes in the film that we shot at the Rainbow Clinic, we get to see the interaction between you and Stephanie, and we also get to know Tanati, Stephanie's husband, who has such an expressive face during the prenatal visits. And this is just an occasion to reflect on the fact, of course, fathers experience stillbirth too, even though their experiences sometimes aren't spoken about as much. And so this is a question for all of our film participants, though I'm going to start with Stephanie. But can you talk a little bit about your husband's experiences going through loss and how fathers can get the support they need as well?
I think for my husband, he's engineer trained, and he's really a lot about results and outcomes and control in terms of like knowing if you put A in and B is expected, that should be what happens. And so our experience with stillbirth just completely flipped his entire way of seeing the world upside down. I think in terms of support, there were a lot of other fathers in our community that reached out to him. But I still think it was very lonely. I think a lot of fathers end up being very lonely. The moms are lonely. I can't imagine how lonely it is for our husbands and fathers. As much as a lot of other fathers would reach out and try to support my husband, unless you've gone through it, it's just really, really hard to kind of understand the depth of pain that they're going through. If your spouse or husband or partner is anything like my husband, who has a very strong belief that he is a caretaker and that he needs to protect his family, it renders them helpless. And he's also not somebody who really likes to talk about his feelings either, which is kind of funny because in the film he's quite eloquent. But yeah, I think it was just a very, very lonely journey for him. Did I answer all your questions?
You did,
Okay.
absolutely. I don't know if Kanika and Debbie, there's anything you'd like to add about fathers' experiences.
Kanika? Yes, no?
Okay, sure. I think,
I just wanted to make sure I didn't talk over.
oh, no, 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 not at all. I think that father's experiences, um, I think for my husband, one of the things that he talked about was just just how he was ignored and the amount of information he wasn't given, as the process was happening. And that he felt like, as things weren't going well, someone should have been talking to him earlier about, what was happening, and that it was hard for him to advocate, and there was just like this sense and loss of power, and they weren't necessarily referring to him as dad or father or husband, and he felt like he constantly had to let them know, like, this is my wife. If anything happens, you have to talk to me. And so just that experience of being ignored, was really hard and difficult. I think in terms of the healing process, he used a lot of art, and poetry. He does a lot of spoken word, so I think he used that to work and help him heal through the process. I remember one time a group of men in our community came over. We were like in the middle of like painting part of the house before everything happened, and they just brought the paint and they sat and they kind of were quiet, but they just painted together and got it done. And so I think some of the things around the house that he was working on, they just came over and helped him. So that was some of the things he did to get involved in, like maternal mental health, from the perspective of dads as well, advocating a little later on.
2011 was a very different time. I know it doesn't feel like that different, but it really was. And just the same way that I didn't receive the support that I needed, neither did my husband. I think that he threw himself into trying to be there for me. I, was broken, and he just wanted to try to put me back together. And so that is how he coped. We didn't, we struggled. Not a lot of people really, I think, were there for him in a way that maybe would have been helpful, but I guess, safe to say the same for me. So I think we've been there for each other. I think he's been very supportive of me in everything that I've done. I mean, right out of the gate, I feel that I began advocating, and so he was there for me for that. And that was, part of his healing journey as well, as just knowing that he was there to support me. But yeah, it's a very different time now with the community that is out there on social media, and the conversations that are being had. It's this is the one area we've come a long way in.
Thank you to all three of you for that. I mean, one of the things that I love about the film, and there's a lot of things that I love about the film, but one of the things that I really love is that we not only get to see all of your stories, but also we get to see your husbands, and that interaction and that love and support. So thank you for, I guess, again, allowing us into your homes and letting us see that side of your life. We have one final question before we go to the audience Q&A. And Debbie, this last question is for you. A big part of the arc in the documentary is about your journey with the Shine for Autumn Act, and trying to get federal legislation passed. We have a new Congress and a new administration. Can you update us on Shine and your efforts to fund stillbirth research and data collection?
We are going to be reintroducing the bill. I wasn't really sure what I was going to do after last Congress because we were so close to getting it passed, and it was absolutely devastating to fall so short. There's been a lot going on, I think it's safe to say, and so maybe we are not where we had hoped we would be as far as reintroduction and what needs to happen and to get this done. I don't even know. It's hard. It's a little bit messy. It's the safest answer, but we are pursuing reintroduction. Just know that, and that the bill sponsors are just as committed today as they were in years past. And we have Senator Daines with Senator Rubio, no longer in Congress. Senator Daines is now the Republican lead in the Senate. I'm very excited to have him. And we are currently working to ensure that the stillbirth funding that does exist, that we have been able to secure for the stillbirth working group, continues. And so if anyone follows me on social media, you will have seen that there was a petition and a survey, because, more than ever, now is the time to, use your voice and to share your stories and help ensure that this remains a priority for your members of Congress, because we've been able to secure this funding since 2022, and really don't want to see us lose that. And hopefully a Shine reintroduction is around the corner. And yeah, just going to keep trucking along.
Thank you so much, panelists, for sharing your stories and your expertise with us. We're now going to turn over to our audience Q&A portion. Before doing that, we'd like to share a link to our event survey in the chat box. Your feedback really helps, inform the content of our future events. So if you can please look for that and fill it out when you get a chance, we'd appreciate it.
Thank you all so much for participating today. We are going to share some questions that we received from the audience and any additional questions we have for the panelists. And if you have any further questions for our panelists, now would be a good time to post them. And so, let's start, I think, with one of the questions that might be best addressed to Dr. Stone, just as a starting place, but anyone can jump in. One of our audience members says that medical legal partnerships have proven most effective in addressing racial access and language and American Sign Language disparities for patients. MLPs provide free legal help coordinated with healthcare provision. Has this proven effective to address stillbirth disparities anywhere in the USA?
It's a really great question, and honestly, I don't know the answer to that question. I don't know if there's data, what the data is on specifically this. We at Mount Sinai, we do have a legal partnership where we do provide free legal aid for certain medical conditions. We haven't needed to use it specifically for stillbirth prevention and our rainbow patients, but certainly it's possible, and if it's been successful in other areas, it certainly may. I think that is an area that needs to be certainly studied more. So thank you for that.
And we got 2 questions during this event about autopsies. The need for autopsy and placental exams is huge. However, the cost seems to fall to families as opposed to being covered by insurance or through grants or standards of care. Thoughts on how that might change, or is that different in other countries or states? And also, how do you recommend talking to parents about the importance of fetal autopsies?
So, I saw that question before in the Q&A, and surprised me quite a bit that autopsies are not covered under certain insurances. So we certainly need advocacy around that. We really do think it's such a crucial part of the evaluation after stillbirth. And not only that, but genetics has undergone so much advancement in technology. Now we have whole genome sequencing, and that's not covered. Certain insurances will cover it for stillbirth, but other ones won't. So I would say autopsy and whole genome sequencing are extremely important to advocate for in terms of insurance coverage, and we just have to keep fighting for it, because we've changed other things, right? So oocyte cryopreservation has now been covered by certain insurances, where 10 years ago it was not covered at all. So we can make headway with some of these things. But it takes more than a village. It takes a whole community of people to continue to advocate for that. I do think that there are, in terms of the question about how do you talk to a patient about it, I think you do need to talk with a lot of sensitivity, because as Stephanie mentioned, she knows what an autopsy means. She's a nurse. She's had to counsel patients herself about autopsy, and it's not easy to think about, but some of the information you gain can be exceedingly useful. And also to know, this is not likely to happen again, or it is likely, and we can do this, to try to help prevent it. But there are some patients that really that can't handle it, right? So there are some other things that we can do. So for example, getting a whole body MRI could be very helpful. So this way, the body's preserved, but they can look at all the different organs and rule out certain conditions. So I do think that we have to keep in mind that we have to be sensitive to a patient's needs, but we can offer other tools as well. So these things are quite important. I think most people are willing to accept placental pathology. I think Stephanie may have mentioned it, or maybe it was Debbie, I'm not sure, but the need for more perinatal pathologists is really critical. In the US, we don't have that many perinatal pathologists. And there's also a lot of variation in the degree of expertise in this area. And this is so important. So I think that, again, stressing the placental pathologies is important.
Thank you so much, Dr. Stone. We had a question that came in about midwifery care. And I would like to start with Kanika on this one. So the question is, how about midwifery care? We midwives are truly involved in antepartum and postpartum care, as well as labor and delivery. And Kanika, I'd like to start with you because I know you've experienced different models of care. As you said in the film, you started your first pregnancy in a midwifery model. You found out you were having twins. You ended up delivering in a hospital, and you remain involved with birth centers that offer a midwifery model. So I'd love to hear from you and also from Dr. Stone.
Yeah, I think, yes, I wholeheartedly agree with you, Susan. As a midwife, we know that just worldwide, there is lots of data that show that midwifery care can help reverse rates of maternal and infant mortality in the US. And this is really connected to the fact that the care, like you said, is antepartum and postpartum. So there's like a continuum of care. There's a continuum of knowledge of knowing your patient. It's a different type of model in terms of the hospital model. You get shuffling around, and Dr. Stone also just talked about how, you have to put stickers and things on the doors because there's just not a continuum of care. There's so many people that are seeing you, and they may not know. And so in my case, because my midwife was seeing me, not only was she seeing me, but she knew my family. She had delivered my peers already. So there was this sense of community care that was already there. And she knew enough about me to say, hey, you're carrying kind of big. I know this is what you wanted, but I need you to get checked out. I need to know what else is going on here. She sits with me and asks me a lot more questions than I think you would have in your typical doctor's office. She wants to know how my brothers are doing and my cousins. And sometimes that gets to more information about what's going on with me and the baby, or like what I'm feeling. And so it's like a truly holistic model of care that I think our current medical system, because it is shaped as a business, does not allow us to fully embrace. But I think, and we also know that we are lacking, we have maternal care deserts. We're also lacking in just and supports. Like midwives can also be supporting OBs, and doulas can also be supporting OBs and transferring this information over if necessary, just like my midwife had to transfer me over. And so I think all of this matters in terms of how we think about care in this country, and not dichotomizing and just separating out birth from community care. And I think that is the connection with midwives that helps center that.
No, I mean, I absolutely agree with so many of the points that that Kanika made. When midwives provide an incredible service, and as she pointed out, there's certainly data out there that shows a decrease again in infant and maternal mortality. We do support midwifery care here at Mount Sinai in our health system. We have several hospitals that do deliveries, and midwives have been present at one of our hospitals, Mount Sinai West, for many years. We just actually opened up on February 1st, I think, a new midwifery practice down in Delancey Street. Not to promote it, but it just shows the importance. We also have a midwifery group within the main hospital. So that's really important, and also doulas as well. So one of our physicians got a grant to supply doulas. We'll be able to supply like 8 doulas for antepartum, intrapartum, and postpartum. And you're absolutely right. The postpartum care is incredibly important because you really need to, there are certain conditions that can develop postpartum as well. So we absolutely need all these different services. And thankfully, in New York State, Medicaid is helping to finance doula care during pregnancy as well. I do think that obviously there's for certain medical conditions, you need to have, if you're really high risk, you have a heart transplant, or you have, severe, whatever severe kidney disease or something like that, you do need to be under the care of a specialist that deals with high risk issues. And I do think that, there's obviously a variety of ways that doctors also get involved with the care, more of a holistic approach, but we do need to focus on that for sure. And I do think midwives and doulas have been underutilized and provide such an important service. And hopefully we're seeing that expand as well.
Thank you both. That reminds me of when I was on my reporting trip in Australia, and there was such a strong presence of midwives in the hospitals, and the midwives and doctors were just working alongside each other and really supporting each other. We had another question asking about any research about a relationship between COVID and stillbirth. That's actually the very first story in my series was about COVID and stillbirths. And what doctors discovered during the pandemic is that some stillbirths were resulting from COVID-19 directly infiltrating the placenta. And so, I talked to pathologists who were all of a sudden seeing, placentas that were withered and scarred, and they didn't know, what it was. And then they discovered that this was, a direct effect of COVID on the placenta. And research then found that unvaccinated women who contracted COVID during pregnancy were at a higher risk of stillbirth. They were also at a higher risk of, premature birth, going to the ICU, and even death. So thank you for that question about COVID. That was something that, at the time of the reporting, there just wasn't a lot of clear understanding or recommendations around, vaccinations, COVID vaccines for pregnant people. And a lot of that stemmed from them not being included in clinical trials. There's another question here about, what is the current education about stillbirth for OBGYNs? Haley said, after our son died during labor in 2022, we were told repeatedly that it was like being struck by lightning. After leaving the hospital, we quickly learned how untrue that is. It's still confusing to me why so many medical professions said this to us. And that's for everyone. But I know, Debbie, you were told, the exact same thing, so many years ago. So maybe we start there.
I don't know. It's a great question. I really think that, from my perspective, going into obstetrics is happy medicine. I've never met a doctor, an OB, who has wanted to talk about the risk of, or the realities of stillbirth. I think that there are, in society, there's a lot of stereotypes around expectant moms and them being nervous and neurotic and a little bit crazy and not wanting to add to that. And so I think that we aren't talking about it. They aren't talking about it as, just wanting to keep us calm and as collected and cool as we can be, when in reality, I've been preaching that, information is power. We put our seatbelt on every day. Bless you. Bless you. And, I often talk about, after I had my son, my rainbow baby, a pediatrician who I didn't know walked in and said to me, listen, whatever you do when you go home, don't put bumpers, blankets, and pillows in your baby's crib. Why? Because your baby can die. Guess what? I went home and I took out the bumpers and blankets and pillows because no one educated me on any of that with my first one. And let me tell you, we co-slept, and, there were a couple moments I was like, uh-oh. But guess what? you don't hear about parents that are staying up all night standing over their baby's crib. You know, they took the information, they did the best they could, and, you know, they ran with it. And I think that until we're actually breaking the stigma that plagues this issue, we're really going to not advance to where we need to be. I think we need to just talk openly about it and, you know, empower expectant moms with information on, you know, concerning symptoms and what they can do to stay healthy and keep their baby healthy. And I think that, you know, it's a great first step, but no one wants to talk about the, you know, the risk of a baby being stillborn. They just don't. And but I think that once we as a society talk openly about it and normalize it and just say these things happen, but they don't need to be, and here's how we need to raise awareness, and here's why we need education, and here's how we support, I think we will be in a much better place. Can I just really quickly also just add on to what Dr. Stone talked about with regards to autopsy? And, you know, many years ago, I had approached the whole insurance needs to be covering autopsies and placental examinations or whatever it is, everything that entails that they're not covering. And then what really dawned on me is that even if insurance companies start to cover the cost of autopsy, it's really who's performing the autopsy. You know, their perinatal pathology requires specialized training. And so while there are still a number of families who do receive, who do get an autopsy, it's not really always done by someone who's trained. And so the information that's collected is really not always accurate, and it's not what's required. And so I think the first, and advocacy is great. I think talking about this issue, but I think we need to find a way to, if it's not going to be the Shine for Autumn Act, right now we need to really be having more conversations about encouraging this kind of training during residency. It needs to be part of the curriculum.
Debbie, thank you so much for that. Our time is running short, so I'm sad to say I'm going to have to ask a final question of everybody. But I think, you know, we made a great effort in the film to incorporate hope into the film, because what we learned is that stillbirth isn't inevitable and that, you know, change is possible. And we've seen those examples elsewhere in other countries. And so I wanted to ask each of you, what gives you hope, you know, given the state of stillbirths in the US, what gives you hope for the future?
Well, I can start a little bit, but I mean, I just returned last night from the UK and attended a meeting in Manchester with all the rainbow clinics there. And what gives me hope is that, well, on Mount Sinai, we started the first rainbow clinic. There's 3 currently now, another one in New York and one in Utah. And we've formed an international rainbow network. So 3 of us are leading the efforts in the US under the guidance of Alex Cecil, reviewing applications. We have 6 applications now in states from Hawaii to California to Pittsburgh, all, you know, six different states. So our goal is to open rainbow clinics throughout every state in the country, and also working on, you know, more and more research regarding this, and potentially a stillbirth prevention bundle. So I do have hope that, you know, we're going to get to a much better place, and I think we will.
Thank you so much, Dr. Stone. Stephanie, do you want to jump in next?
What gives me hope? Places like the Rainbow Clinic, I think, really it restores a lot of faith that's been lost. I'm a nurse and I lost a lot of faith in our health system. And so having doctors like Dr. Stone and her team and clinic really give me hope, because despite the loss, and I'm careful to use that word, that phrase, there's still hope in that we can still have babies. Can you hear me? Okay, yeah, sorry, my AirPods died. I have 2 living Earth babies after Elodie, and so just to be able to have children, because I know that's not always an option. Also, you know, Debbie and Kanika kind of went through their losses in a very different time, and I call them celebrities in the loss community, but there's this network of moms and families and loved ones that are much more supportive and accessible now, and I see that growing even more so through different like platforms. And I think that kind of hope to be able to support another, just one mom or family, I think is encouraging.
Thank you so much, Stephanie. How about you, Kanika?
Yeah, so what gives me hope is Stephanie definitely hinted on it, was, 13 years ago was a very, almost 15 years ago was a very different time. In this stillbirth journey, it was quiet. There was no one for me to talk to it about. There was no options for therapy. Yes, I got I'm sure it still happens, unfortunately, but yes, I was the postpartum mom that, where's the babies? That had to sit in the waiting room with all the other moms. So just, yeah, knowing there's a rainbow clinic and like these places exist definitely give me hope. Definitely how we have grown in terms of midwifery and doula models of care and increasing the workforce to support um, the birthing community and to support doctors gives me hope that hopefully we are not that hopefully, I know we're saving moms and babies through just that one phone call to your doula that says, hey, this is happening to me. I don't feel well. What do I need to do? But I'm going to stop so Debbie can chime in.
Thanks, Kanika. The fact that we're having this conversation, the fact that you made this documentary and that, Dua, you covered so much of this issue and raised flags and wrote tremendously smart and much needed articles that really highlighted so much of this issue. To Kanika's point, almost, 14 years ago, when I lost Autumn, no one was talking about stillbirth. No one. And nothing was being done. And here we are. And there's rainbow clinics, to Joanne's point, and there was an NICHD stillbirth working group, which published 2 reports with one with real actionable things that we can be doing to improve outcomes in this country for families, and that there's federal stillbirth legislation, and that there's a community for the first time who is supporting one another and being there in ways that have never happened. And I just hope that for anyone who is seeing this documentary who has lost their baby, that they are empowered and inspired to find a way to honor their baby through, any of the ways that they see in this film. But I didn't know, I didn't have anywhere to look, and I didn't know what to do, and I just did. And, having someone, being able to watch this film and be inspired and be like, I can do that, or, oh, I didn't know I could do this. I really hope that it helps. And for those who haven't experienced a loss and are there to support others, that they see it and are like, oh, I could do this for them, or I could tell someone that they could be doing something like this. I just think that the more we talk about it, the less it's ignored, and we're in a much better place than we've ever been before. And I think we just need to carry on with this momentum, and I hope that we do, because it's important and it's needed, and I would hate to see us lose any sort of progress that we've made. So, yes.
You all for such thoughtful remarks. That is our time for today. I want to thank our panel for this insightful discussion. I want to thank our audience for joining us and for your really thoughtful questions. Again, this event has been recorded, so you'll receive an email with the full video of today's discussion. A link to our event survey will also be added to the chat box. We appreciate your feedback. The film is available on ProPublica.org/beforeabreath. And from all of us at ProPublica, thank you for joining us and have a great evening. We look forward to seeing you next time.